Dr. Ron approached me about doing something at the conference on kind of short notice, I thought it would be good just to have a few, like a framework of case studies that we could hopefully generate some discussion off of. And my hope is that it's interactive and you guys can just kind of jump in with questions and comments as we go along. Something I'll start with is background just sort of on my approach to oncology and working with cancer patients. I guess I center mostly around three main kind of avenues or approaches, and these depend on what phases of treatment the patients are in. But the first one would be working. Sorry. You guys hear me okay now? Better? All right. The first one, I usually talk loud enough anyway, so probably not much difference, but the first main kind of avenue which naturopathic oncologists work with patients is in more of a supportive and complementary approach to when patients are going through traditional treatment. So looking for ways to decrease side effects, decrease collateral damage of cytotoxic therapies. Secondly, we're looking for ways to take advantage of any non-toxic integrative therapies that might have anti-cancer effects, such as IV vitamin C, such as things like mistletoe, which is a therapy that I use a lot. And that could be either directly or indirectly. You know, some of these naturopathic and integrative approaches are working more through the immune system and aren't maybe directly impacting the cancer cell, but indirectly, it's helping to get a hold of the disease. And then lastly, I would say that we focus on prevention, whether that's primary or secondary. This is where we're doing the detective work and looking at possible root causes, working on diet, lifestyle, environment, all these things that kind of fall under the epigenetics category, if you will. What are the patients doing to either improve or increase their risk factors, whether they've already been diagnosed, whether they are, have a strong family history and a strong genetic risk. So those are kind of the main three pathways in which I see naturopathic medicine and integrative oncology kind of working directly with patients. So with that said, we'll jump into the case studies here. And these are a couple of patients that I had when I was working at CTCA. And some of my approach has changed a little bit since then, since joining the Riordan Clinic. But I think this will give us enough pertinent information and a good enough kind of setup to get some questions and discussion going. So the first case is a colorectal cancer patient. And this guy, the history is a little off there, but I ended up seeing him initially when he was about to start his chemo and radiation prior to his surgery. So he ended up getting surgery and getting the right side of his colon removed, but prior to, they do neoadjuvant chemoradiation with an oral drug called capecitabine or Xeloda. And so I first saw this patient when he was getting ready to start that phase. They ended up upstaging him to a stage 3 based on the fact that they found a few lymph nodes with the surgery. But when I saw him, we were like, our game plan was, okay, how do we get you through the chemo and radiation while at the same time working on some of that prevention, right? So past medical history, high blood pressure, hyperlipidemia, arthritis. You'll see that this guy kind of has a really high inflammatory picture. He was a truck driver and had a very sad diet, meat and potatoes. Was overweight, but had lost a lot of weight just leading up to and after his diagnosis. Didn't have a great appetite when I first saw him. Did have Lynch syndrome, which some of you might be familiar with, but anytime you see family history of endometrial and colon cancer, it usually is a dead ringer that there's a Lynch syndrome going on. This is a hereditary syndrome that sets you up for high risk for those types of cancer. And so his offspring need to be involved in active surveillance and colonoscopies and things like that much earlier on because of this genetic risk factor. And proactive surveillance as well, engaging with holistic practitioners, looking at diet, looking at lifestyle, all these things, right? So signs and symptoms, having weight loss, loose stools, sleep disturbances. I mean, see that with everybody, like Dr. Ram mentioned in his beautiful lecture he had earlier. Most patients with cancer are going to have sleep issues. Joint pain from the osteo, fatigue, and then just some of the basic labs that he had when I first saw him. He was anemic. He was losing some blood through the stool. He was having tarry stools, and his CEA, which is a kind of a general tumor marker for colorectal cancer, and all GI based cancers was elevated. So we have the first initial visit with him. Kind of get a pulse for where he's at functionally, but then we always want to test, right? Because we can't, kind of do guesswork at this point. We need to test, make sure that we know where the terrain of his body's at, see where the deficiencies are, see which pathways aren't working well, whether it's hormones or immune system or inflammation or all of these. So we did kind of a full panel on him, and these are just some of the highlights of things that we found. It wasn't, this isn't all inclusive, but we did, of course, at the bottom, we checked his G6PD to rule out, that issue, so we could do IV vitamin C. Nagalase, I don't know how many of you are familiar with nagalase. It's an enzyme that is usually elevated when the immune system is suppressed. It's involved in breaking down a protein called GC-MAF, which is one of the proteins that's involved in recruiting our immune cells when there's chronic infection or cancer or something like that going on. So nagalase is kind of a soft marker you can get for how their immune system's functioning. And if it's elevated, it means that it's blocking a lot of that GC-MAF activity. And it's you can order it, most of the standard labs will do that. And then moving back up the list here, hormones. I'm sure you all have seen this picture here with low thyroid, flat adrenals, and low, sex hormones, right? Low normal sex hormones. So this guy, he's 63, and unless they're supplementing with testosterone or DHEA, most males in that realm are going to have low, or at least low normal testosterone. So we factor that in. Tumor markers, we already had a CEA, but we also look at circulating tumor cells. These are done usually on liquid biopsies. There's a number of different companies out there that do that. Biocept is one that I use a lot. He didn't have any, which is good. Inflammation, of course, we checked his CRP, and it was significantly elevated. As far as things that popped out of his nutritional panel, low vitamin D, and less than 20. So anything less than 20 is considered a bad prognostic factor, especially in colorectal cancer. Low vitamin D has been associated with just about every type of cancer, but lower than 20 with certain types of cancer, that kind of shows maybe a worse prognosis. Low on all his antioxidants, again, he was a meat and potatoes kind of guy, not eating a lot of colorful fruits and vegetables. Minerals, he had low iron, probably from the blood loss, low zinc as well. And then again, this inflammatory picture with the high omega-6s, low omega-3s. So lots to work on, right? So what did we do? This was, again, kind of his initial plan. We, IV vitamin C obviously is kind of one of the cornerstones of my practice, and obviously the Riordan approach as well. So we, kind of titrated him up through the normal process, 25 grams, 50 grams, 75, checking those post-C levels. Mistletoe is another one of those kind of cornerstone therapies that I use with a lot of my cancer patients. It works very well. It's very synergistic with IV vitamin C. Its main effects are through the immune system. It's stimulating an immune response through the compounds called lectins. A lot of people know lectins more from the dietary standpoint and, Dr. Gundry's protocol, things like that, but these plant lectins that are in the mistletoe actually cause an immune response, right? I guess fairly similar to the way they can cause autoimmune response in the gut. These are causing an immune response, a localized immune response, which is harnessing these macrophages, neutrophils, T cells, and alerting them, right? That's the hormetic, right, process that Dr. Ron touched on earlier. So again, similar to IV vitamin C, there's a titration process or an induction therapy that we do with mistletoe. It is given 3 times a week, and we're titrating it up until, not with vitamin C, we're not looking for a blood concentration, but we're looking for a skin reaction. And you want to look for a specific type of skin reaction that's less than 5 centimeters. That tells you that they're getting the immune response that you want, and at that point you basically are holding them at that dose, and depending on where they're at with their conventional treatments, we'll usually get them into this rhythmic dosing where they're doing those shots 3 days a week for 4 weeks, and then they take a 2-week break, because if they just stay on it, they tend to build up a tolerance and you stop getting that reaction. Of course, we got them on vitamin D and iron to replete those. I like the gentle iron, the iron bisglycinate. It's a lot easier. You can also do IV iron, Venofer. But again, we're not keeping them on iron long term. We're usually just getting them on enough until, wherever they're having the blood loss stops and their levels are back up, in the normal range. We don't want to push iron too much because it's an inflammatory, it's a Q phase reactant. So we don't want too much iron either. Probiotics, I like the VSL brand. You can get it commercially. A lot of times insurance will cover it. It's a very high dose. It contains 8 different strains compared to a lot of the over-the-counter ones that just have 1 or 2. And most of the cancer research with the microbiome, you really want the diversification of the microbiome. So as many different strains as you can get, the better. Fish oil, again, he had low omega-3s. And again, with the history of, high cholesterol, hypertension, arthritis, you really needed to push that, the anti-inflammatory pathways and the LOXs and things like that a little more with a higher dose of omega-3s. I think 2 grams is minimum, but I try to get patients up to 4 grams if they have a lot of inflammation going on. And you can do that through other ways. You don't need necessarily fish oil. They can get it through flaxseed. They can get it through chia. There's other ways to get omega-3s, so not everybody likes taking the big, huge gel caps of fish oil, and the liquid usually doesn't taste very good, so sometimes you got to get creative with other ways of getting omega-3s in. Melatonin, I know we're going to have a long discussion on that tomorrow or Saturday with Dr. Schallenberg, so I won't steal his thunder too much, but yeah, melatonin, especially with cancer patients, very well researched. It's one of my Swiss Army knives. It helps with sleep, helps with the immune system, has direct and indirect anti-cancer effects. And so, again, it's usually one of those cornerstones that I put patients on.
Dr. Russell Ryder made a big point. I was just talking to him the other week, and he basically said it's one of the premier ways to prevent metastasis, which was new to me, but man, that's what kills people. And so if you can prevent that, you can keep people in a holding pattern for a long time.
Yeah, absolutely, 100%. So a lot of these things, even the mistletoe to a certain extent has been shown to have anti-angiogenic properties. There's other natural products that can help with spreading tumors in certain tumor types, things like modified citrus pectin. So there's so many tools out there. Again, cancer patients usually come in and some of them want you to just throw the kitchen sink at them, right? Just give me everything under the sun, or they're already maybe taking everything under the sun. And so you do have to get strategic and say, look, there's only so much you can do. There's only so much the body can absorb. We can't have you taking 200 supplements a day. And so some of my work with patients initially, especially cancer patients, is kind of figuring out a game plan where these are the things we're going to focus on. I'd rather you be doing these 5 or 10 things 100% than doing 100 things 25%, right? Acupuncture, I mean, I try to get most of my patients, especially while they're going through active treatment, I try to get them seeing an acupuncturist because it can help with so many of the side effects: nausea, vomiting, fatigue, pain. Cannabis as well. I mean, we could do a whole hour presentation on cannabis and cancer. But a lot of exciting research with more of the we know it helps with a lot of the symptoms as far as pain and appetite stimulation. But countries like Israel, Canada, where they've got a lot of funding and they've approved it for medical use already. They're way ahead of us and are doing human research with cannabinoids as standalone treatments for late stage cancer. So I think in the next few 2 to 5 years, we're going to be getting a lot of those results back. And one of the neatest things I've learned about cannabis is not necessarily about the plant, but about the fact that our own bodies contain what's called the endocannabinoid system, which is this whole network of receptors that you can think of sort of as the internet of your body. It's really the way that all these different types of cells in our body communicate. And it just kind of blows me away that all of our human cells have a plant receptor on them. So I think that just kind of is something to really watch for. I think we're going to continue to learn a lot more about cannabis and its medicinal uses. But for him, we had him using it to help with his appetite. Again, he had very poor appetite when he came in, and with his pain as well. I've been able to keep a lot of patients either on very low doses of opiates or get off completely using cannabis. So it's a great tool. Exercise, of course, stress reduction. These are all things where we're working on more of that lifestyle and getting patients to reduce those risk factors, so that risk factor profile. I like the mindful-based stress reduction, John Kabat-Zinn, all that kind of stuff. Some patients either really get into that stuff or they're like, you gotta really force them into it. So I don't push too hard, but if the patients take hold of it, I think it can be a powerful tool. And then diet. With colorectal cancer, there's not one type of diet with cancer. So everybody wants to, say that, there's an anti-cancer diet out there, or, the Gerson diet or ketogenic. And I think they all have their place, but specifically what we can agree on is that you want to avoid processed foods. You want to avoid refined sugars. And you want to avoid dirty animal protein, I'll call it. It's probably not the best term for it, but when you're eating animal protein, you want to eat as clean a source as possible, right? Organic, grass-fed, hormone-free. I think a lot of the negatives that come along with animal protein, as far as the studies that have been done, are more due to the industry than they are actually the animal protein itself. So get him eating a little more fish, a little less red meat. He was kind of a steak and potatoes guy, like I said, and daily tree nuts. There was actually a study that came out a couple years ago where they looked at colorectal cancer survivors and tracked their dietary habits. And among the biggest thing that stood out were patients that ate daily tree nuts had about a 50% less risk of recurrence, their colon cancer, which I don't know about you guys, but I think that's mind-blowing just from daily tree nuts. So if that was a drug, you'd never hear the end of it, right? So I get my colorectal cancer patients on the daily tree nuts right away. And again, that's everything except a peanut, right, basically, because they're not really nuts, they're legumes. And more healthy fats, too. Yeah.
On the tree nut conversation, the laetrile that's in the apricot pits, are you including those in the tree nuts as well?
That would not be included in tree nuts. Apricot seeds, there's, the amygdalin or vitamin B17, laetrile, goes by many names, is present in apricot seeds, almonds, apple seeds. I'm not a big fan of the laetrile. There's been some preliminary research done on it a long time ago. It didn't really show a lot of great results in those patients. Did show that it could cause some serious adverse effects, given that it has the potential to break down into cyanide in the body. So I'm a little cautious when patients come in and they're eating 30, 40 apricot seeds in a day. If they're eating, 10 or less, if it's something you could feasibly eat, as far as part of a normal healthy diet, I don't make too big of a deal out of it. But I know there's clinics in Mexico that do IV Laetrile, and it's just not something that's part of my repertoire. But again, as far as the original question, it's not included in tree nuts. Yeah, we can do questions, because I think I'm done with this case.
Oh, let's do questions. If you have questions, raise your hand.
Jump on in.
When you're doing these wheels of the mistletoe, is there a particular location you're doing, and what's your source?
Yeah, in the abdomen. They can also be done in the upper arm and the thigh, but typically we're doing them in the abdomen unless they have some sort of issue. Some of the contraindications are if they have, you don't want to inject. Well, the way I do it, you don't want to inject directly into a tumor, although there are some doctors in Germany that are doing intralesional injections with mistletoe. You don't want to inject in any sort of rash or open cut or anything like that. And then breast cancer patients, you would avoid doing the upper arm in them because of the risk of lymphedema and things like that. So, at least on the side that they have the breast cancer. There's only one pharmacy in the U.S. you can get the mistletoe through. It's called Uriel Pharmacy, Uriel. Their source is from a German company called Helixer. And there's a couple of other companies in Europe. One that we used to be able to get here was called Iscador, that was made by Weleda. And so we're kind of just isolated to the Helixer product right now, but Helixer makes a great product, and they've put out as much research as any of the mistletoe product companies. So thank God we have the Uriel Pharmacy, because nobody else is really stepping up and putting their neck out there to try to make this available in the U.S.
What's the concentration of the mistletoe in the pharmacy?
So there's 3 different types of mistletoe. A, M, and P, and it all depends on the host tree that they're cultivated from, because mistletoe is a parasitic plant. It grows on other trees, and depending on the trees they grow on, they have different profiles as far as how strong they are, and these lectins and these different viscotoxins that they carry. So they come in these boxes of series of ampules, and they basically start at 1 milligram and can go all the way up to 100 milligrams. And there's a protocol in which the patients will work their way up through the boxes. And so if you go to the Helixer website, they have a tab for healthcare professionals, and they walk you through all the protocols on how to do it. It's very simple. You usually will have the patients do their first test dose in the office to just make sure they don't have an allergic reaction, and then you'll send them home with the kits and they'll self-inject. Yep.
I have a question. What source of cannabis? What's your source of cannabis? Right
Oh,
here.
sorry. Looking around here.
Yeah, what source and how much?
Yeah, that's the question, right? Because there's, it's a difficult landscape to navigate. We've got states that are licensed, states that aren't licensed. You've got stuff you can buy on the internet, stuff you can only get through dispensaries, stuff that's FDA approved, actually. There's synthetic forms of THC and now CBD that have been approved for, special use cases. When I was in Arizona, which is where I moved from, it was a lot easier because patients could get their medical card and go and access products from dispensaries. Now that I'm in the great state of Kansas, it's a little different. Sometimes you got to get creative. Depending on what they're using it for, I think that a lot of the studies that they're looking at it for the anti-cancer effects in other countries, they're using a blend of THC and CBD. It's not just one or the other. And so while I think there are benefits to just doing CBD, which is what you can buy on the internet, I've seen that just help with pain and even other types of autoimmune conditions. It's been well documented it can help with seizures, but for the anti-cancer effects, I think you really need the THC component as well there's a synergy that happens with those two cannabinoids. And so if you look at the phase 2, phase 3 studies that they're doing in Israel and other countries, they're using a 1-to-1 or a 1-to-2 ratio of THC to CBD.
I have a question about diet. Do you ever look at methionine restriction?
I'm sorry,
Do you
repeat
ever look
that?
at methionine restriction
Yeah.
as far as diet's concerned?
Yeah, I mean, I think, with this guy, we do a full nutritional panel, so we're looking at levels of all those different amino acids and minerals, and sometimes we get clues as to, particularly with things like homocysteine that, you might have to work upstream. Methionine, is one of those as well. This next patient we'll talk about, she had a lot of methylation issues, so we had to work on her with some of those things.
Could you, or do you have anything to say? Would you give some of your thoughts about the use of DMSO?
I haven't done a lot of DMSO. You mean like topically or IV or IV?
IV, I have in the past used 99.9%.
You use it like from a chelation standpoint or for more anti-cancer effects?
No, more anti-cancer together with the vitamin C.
Yeah, I know it's one of those things that's out there. I haven't dipped my toes into that combination of therapies. What's been your experience?
Good, actually.
Yeah.
Very good. Good results. And there was one thing that I did notice that we had difficulty getting it from
Yeah.
the supplier that we were getting it in Italy. And we have not been able to get it from a supplier that I would be happy with at the 99.99% grade.
Do you have any contacts in the horse racing industry?
Yeah, well, that's where we were looking, actually. In fact, we were looking at veterinary supplies.
I mean,
because that's where it is.
I'm not saying, but I'm saying,
But I would say one thing that I noticed, and it just came over the years that I was using DMSO. But I noticed that when we stopped using it, I had to use painkillers. Yeah. When I was using DMSO, I never had to prescribe painkiller. Whether that's a coincidence or not, I don't know. But I think DMSO may have a lot to do with it because we used it on people with intractable pain, like arthritis and other things, and we got good results in, I'd say, well over 50% of cases.
I mean, yeah, if you look at, one of the biggest problems we have in our country now, that the opiate, epidemic, I mean, we need other options for pain relief. And you're not the first one I've heard that from about the DMSO, and I think there's a lot of anecdotal evidence out there. And definitely another tool, but, it can be hard to get, I think.
Let's go ahead and do case 2.
Okay, so we'll kind of zip through this one, and hopefully we'll get a few more questions. So this was a breast cancer patient, early stage. So I saw her again before her surgery. So our first visit was right before she was starting her chemo. She was getting a pretty standard chemo regimen, AC followed by Taxol. It's got a fairly solid toxicity profile as far as these drugs go. They're older chemotherapy drugs, but they're still used as standard of care for breast cancer. So we were, again, game planning for more supportive complementary therapies that will help to decrease side effects and decrease collateral damage with this patient while she's going through this phase of her treatment. She was ER/PR positive, HER2 negative, so a little bit more favorable as far as the tumor characteristics. The opposite, when they are hormone negative and HER2 positive, it's a little bit worse prognosis. And she was negative for the BRCA gene as well, which is a risk factor for not only breast cancer but ovarian cancer. And actually some other cancers as well. There's 2 different BRCA genes. Pancreatic cancer can also be included as a risk factor within those. So she started the chemo. There's some of her other issues. Oh, she had a long history of IBS, hypothyroid, and she had just right around the same time she was diagnosed with breast cancer, she was diagnosed with type 2 diabetes. And I don't know about you guys, but I see that a lot in my patients where there's these kind of concomitant diagnoses of diabetes or metabolic syndrome around their cancer diagnosis. And I think that, that's not a coincidence, right? I mean, especially when you read up on the metabolic theory of cancer and everybody that's I know one of our speakers here, Dr. Winters, has written a lot on that. She's got a great book called The Metabolic Approach to Cancer. So anyways, that was something that we, obviously needed to work on with her. She was just going into menopause as well, so dealing with hot flashes, insomnia, mood swings, kind of your typical case here with breast cancer patients. Labs weren't anything, no CBC abnormalities. She did have high glucose, elevated LDH, which is kind of a soft tumor marker. It just kind of looks at, can look at inflammation and cell breakdown. ALK-Phos, kind of similar. So more kind of integrative or functional testing. We, with the history of IBS, I ordered food allergy testing. We did identify she had issues with dairy, which she ate a ton of. I mean, she was the lady that ate ice cream every night and sometimes for breakfast. And she also had issues with nightshades, which is one of those that I see come up frequently on food allergy panels. But it's not one of those things that intuitively patients think cause problems, right? They think of them as healthy foods. So I think food allergy testing, for all of its criticisms and some of it might not be as valid as we'd like as far as the reproducibility of it, but I think it can be a useful tool for especially when you have patients that you really need to remove as many obstacles as you can. Low vitamin D, again, I don't know about you guys, but 95% of the patients I test are low unless they're already on supplementation. Her G6PD was normal again. Nagalase was elevated, so we knew there was immune dysfunction. Her tumor markers, so she had. So all of her breast cancer, all of her standard tumor markers were normal. CEA, 15.3, 27.29, which are all breast cancer tumor markers. We didn't check circulating tumor cells because in early stage breast cancer, it's not a validated test. But one of the other things I use when I do have these early stage breast cancers is a test called urinary iodine. And this has been closely associated with breast cancer. And so I think that I kind of see that as a bit of a surrogate for the circulating tumor cells.
Japanese women have 1/5 the incidence of breast cancer, and they tend to consume about 12 to 13
Correct.
milligrams per day. On the average, in some places like northern Japan, it can be as high as 50 to 60 milligrams per day.
Yeah, so I was reading a paper the other night about the connection with low dietary iodine and the increasing prevalence of breast cancer in younger women, especially in the U.S. And so I think, yeah, that's a point well taken, Dr. Ron. But that's another great test that you can use as a soft marker, the urinary iodine in breast cancer. Hormones, of course, breast cancer. She was hormone positive, so we did a full hormone workup. She had, she already had a history of hypothyroid, was on Synthroid, but she had never been tested for Hashimoto's. And so we found that she did have antibodies, and that kind of changed. She also had high reverse T3, which requires a slightly different approach as well. But most cancer patients or patients with other chronic infections and chronic disease are going to have a higher reverse T3. Correct, Dr. Ron?
Yep.
Yeah.
Absolutely.
So adrenal, kind of an inverse adrenal curve, cortisol curve. Again, she had trouble sleeping, so she was just pumping out cortisol all night, sitting there laying in bed. Am I gonna die? What does this do to my life? I have breast cancer, oh my gosh. She was one of those women that really wore her emotions on her sleeve, for better or worse. And then we looked at, obviously, the estrogen breakdown. So this is looking at the different metabolites, estrogen metabolites. She did have a high 2 to 16 ratio, which is kind of one of the main ones I look at. The the 2-OH being the better form and the 16-OH being the not so good form that is associated with a higher risk of breast cancer. So a lot of that's dealing with methylation, dealing with her environment, getting plastics and BPA and all that kind of stuff out of her immediate environment. How are we doing on time?
Couple more minutes.
Okay. So this was kind of what her plan looked like. Again, IV vitamin C and mistletoe. We also had her on the DIM and I3C, which are good ways to help balance out the estrogens. Probiotics, again, another one. Magnesium helps with hot flashes. I like to use that as kind of a first line for hot flashes, but there's a lot of other things you can do to help support hot flashes. Acupuncture, evening primrose oil, hesperidin.
One point I would make is in the research on my book, Hidden Epidemic, a vast majority, I'm going to say somewhere between 65 and 85% of breast cancer has lymphatic drainage associated with infected teeth. And it should, in my opinion, and I submit, should absolutely be baseline testing for anybody with this condition.
Yeah, I think, I mentioned earlier that these are patients I saw a couple years ago, but since being at the Riordan Clinic, some of the tricks I've picked up are always asking about that dental history, and I 100% agree. So coenzyme Q10 is a specific recommendation for any patients that are going through doxorubicin chemotherapy because it does carry quite a high risk of long-term cardiotoxicity. With those patients in the coenzyme Q10, we actually have very good studies shows can mitigate that risk significantly. So she pretty much will need to be on coenzyme Q10 for the rest of her life. Again, where's coenzyme Q10 working? The mitochondria, right? So the mitochondria of the heart, that's what's getting affected by the doxorubicin, and hence why the coenzyme Q10 has a protective effect. Melatonin, vitamin D. With her diet, we removed those sensitivities and tolerances she had. I did recommend a ketogenic diet with her. I think with my patients that have a tough time losing weight, that they have a long history of obesity, they're high carb eaters. I do think you can't do it overnight, but getting them into a ketogenic approach as well as with intermittent fasting, I think is a good approach for these patients. And so we also with this lady had her doing fasting before and after her chemos, which I do with all my breast cancer patients, and I do with a lot of my other tumor types as well, but specifically with breast cancer, the evidence is really mounting up that you can decrease a lot of the inflammation that's caused by the chemotherapy by having patients fast. This puts them into their cells into more of a protective state, and the cancer cells are incapable of making that switch. Put her on iodide, selenoiodide, to help with the reverse T3, get that down a little bit, Hashimoto's. The exercise, yoga, rebounders, I like doing those for patients, especially if they're just getting started and they need kind of a gentle movement. And then also for the lymphatic support. And then had her doing, have you guys heard of EMDR? It's the rapid eye movement. She had a past history of trauma, actually several incidences of trauma throughout her childhood. And this is a reprocessing kind of therapy that some therapists are trained in. We had a gal at CTCA that did a lot of this with our patients that had emotional trauma history and sexual trauma history, all kinds of things, and saw a lot of great results with that. So just a little plug in for the EMDR. All right, any time for a few more questions or?
Just one or two more questions,
Yeah.
and then we need to wrap up. Yeah.
I see your protocol was IVC once weekly during chemotherapy,
Yeah.
2 to 3 times a week after.
I'm glad you pointed out. That was actually an error. We actually did twice on the weeks that she had the chemo and 3 times on the week she wasn't.
And how do you time that? Also, intake of oral vitamin C. Do they do that on days they get chemo, take it orally, or do you
Orally,
take it
I'm
off?
fine with them taking that the day of, but we'll usually hold the IVs 24 hours before, and at least 24 hours before and after their chemo.
And then would you preferentially want to give IVC 24 hours after chemo? added benefit to do it quickly?
Yeah, that 24 to 48 hour window I think is ideal.
Yeah,
Yeah.
I agree. Okay, got it.
How do you test for nagalase?
It's a blood test.
Blood test?
Yeah.
And then do you use the GMAP to bring it down?
No, it's a good question. There's been studies done with the GCMAF. In certain tumor types, it seems like it does help, but the results haven't been as good as we would have hoped as a direct immune booster. And again, the nagalase is more of a marker, right? So we're doing other immune therapies that we can track their effectiveness through the nagalase, but we're not just looking at it as a target as we need to bring down the nagalase. Yeah.
How are the patients doing? And
They're both actually, these aren't my patients anymore since I've moved on, but as of a few months ago, they were both still cancer-free. So these are plans that I think, again, these are patients that I started working with them very early on. Both of them weren't, advanced stage yet, so that helps. But I think the earlier on we can get our therapies and our approaches working for these patients, the better they're going to do long term.
So as you can see, we're really happy to have Dr. Timms on staff, and so let's give him a big hand. Good job.